Hello, welcome to another in our series of digital slide review and sign out. I'm Dr. Lewis Hassel from the University of Oklahoma Health Sciences Center, and our program is part of the Digital Anatomic Pathology Academy, made possible by the Digital Pathology Association and Path Presenter. I'd like to share with you today a quite interesting case, something that's somewhat intrigued me over the course of my career, as I've encountered it fairly infrequently, but always wondering kind of what it represents. So the patient is a 40-year-old woman, and she's had a rather lengthy history over the last year or so of abnormal menstrual bleeding. She's been worked up and had a variety of interventions looking at her coagulation status and other circumstances, but she declined to have an endometrial biopsy to investigate this, which is a significant finding. She's on no hormonal therapy or other therapies that would explain this, and being that she was beyond childbearing intentions, they opted to do a hysterectomy. Well, first I thought it would be interesting for us to just think about what the causes of abnormal premenopausal bleeding can be, and therefore what we might be looking for as we examine such a specimen. First of all, there are the anatomical things like polyps, telangiectasias, occasionally adenomyosis, leiomyomata, that can all interfere with normal menses and the process of efflux of the menstrual detritus. Sometimes patients can be pregnant or have early spontaneous abortuses without even recognizing that they've been pregnant, and that can occasionally be the cause for premenopausal bleeding. And of course, hyperplasias and neoplasias do occur in this age group once you get past 35 or so. Beyond that, there are a number of sort of non-anatomical things that can cause bleeding, including ovarian dysfunction or hypophyseal dysfunction in terms of hormones, infections. We've mentioned coagulopathy, intrauterine devices, or other iatrogenic issues can lead to abnormal bleeding. And then always there seems to be a category of we just don't know, or we just don't find anything that seems to explain the bleeding. So in this patient, we received a hysterectomy specimen, and I'll turn our right side up here so that we can approach it from the top down. As you can see, there's no intramural masses. The serosa looks pretty bland. The endometrium has a fairly nice secretory appearance, and dilated glands with a bit of secretion in them. A little bit of interdigitation in terms of adenomyosis, but not such that you would expect really gross abnormalities. And so as I passed through this section, I thought, well, it looks like just a normal secretory endometrium with no abnormalities. But then something caught my eye, and there just seemed to be a little bit of a slight abnormal coloration of the muscularis down here. So I thought I'd take a little closer look. And so indeed, I came into high magnification, and lo and behold, this tissue was literally chock full of eosinophils, all through the perivasculature into the myomatous tissue for quite a ways here in this smooth muscle tissue. And yes, these are all eosinophils here. I didn't see any atopic history in her background. I didn't see any particular high-risk drugs that I would recognize. But I went back to the chart and looked a little further. And in fact, she did have at least registered an allergy to plastic tape. Well, I don't think that was the inciting antigen here in the uterus by any means. And she was taking a number of medications. She was using medical marijuana for the for the pain, I guess the discomfort. She had a couple of minor pain relievers as well, some non-steroidal anti-inflammatory agents and so forth. So nothing that looked immediately like a strong cause for this sort of myometrial infiltration by eosinophils. So I looked a little further at that point and came back to the endometrium here. And although it looks fairly typical for a secretory phase endometrium, with considerable search, I was able to identify a few fields, not infrequent, but a few areas where we had stromal eosinophils. I could not find plasma cells, but the stromal eosinophils were fairly convincing, even some in the degranulating stage, and maybe a cell or two like this that suggested a plasma cell. So in fact, this patient had an eosinophilic endomyometritis. Well, I searched for that, did my literature review, and I could not identify much that would link this specifically to anything in her circumstances. There were a few cases where in a postpartum patient or patients who'd had a prior endometrial curettage where this kind of change had been identified. There were a few other cases of chronic endometritis and eosinophilic endomyometritis. And in fact, in maybe a third, 2/3 of patients with chronic endometritis, eosinophils will be one of the accompanying inflammatory cells that can be identified. The other option, of course, that I considered and was unsuccessful in elucidating was some sort of abnormal immune response due to a systemic hapten like a drug or an ingested allergen. So by and large, this ends up as being kind of an unknown etiology for her, but may well be the cause of her abnormal bleeding and the cramping pain that she experienced. So our final sign-out diagnosis then was eosinophilic endomyometritis, and we'll turn it back over to our clinical team to try to elucidate what might have been the inciting cause for that inflammatory response. Well, I hope you enjoyed that little sojourn through a truly minor entity in GYN pathology, but something that may occasionally pop up. If you like this, please don't hesitate to hit that like button. And of course, we welcome subscriptions and are eager to put out new videos, both in response to your suggestions, to the interesting cases that we may ourselves come across in our service here at the University of Oklahoma, or in the referral cases that come our way as well. So until next time, thanks so much for joining me.